So we will start off with the bronchoscopy quiz. This was the picture that was put up, and the questions asked were: what is seen? Is there a vegetable foreign body which is seen? Should it be removed by a flexible bronchoscopy? And should it be localized by a flexible bronchoscopy and removed by rigid? So one of that was true, and what we can actually see is a sharp-edged radio-opaque foreign body at the entrance of the bronchus intermedius, and basically you have to confirm it by a flexible bronchoscopy and you have to remove it by a rigid bronchoscopy. The reason is because it is a sharp metallic object. You should not try to remove it with a flexi. And this was what was there. Okay, the second question was, what is not true? So this could be associated with a subglottic stenosis. You can have cardiac defects like VSD, you can have renal agenesis, and you can have submucous cleft palate. So yes, incomplete, it is due to the incomplete separation of the vocal cords. We had seen one such case during the bronchoscopy sounds that we were showing, the respiratory sounds. Subglottic stenosis, submucous cleft, cardiac defects, all can be there, but renal agenesis is not common. So that was the answer. The third question that we had was, this usually presents with respiratory distress from birth, may develop permanent pectus excavatum. In mild cases, you do nothing, just wait and watch. And in more severe cases, some anti-reflux measures can be given. So one of them was not true, and definitely this was a laryngomalacia, and we all say that it is unlikely to present from birth. So there can be, you might get laryngomalacias from birth, but not common. So if you get respiratory distress, stridor from birth, then don't think of laryngomalacia as the first diagnosis. So this was the 45-day-old girl with recurrent aspirations, and this was what was seen. So the question was, vectoral anomalies may be associated, charge anomalies may be associated, tracheomalacia is rarely seen in such cases, and FEES shows evidence of aspiration. So you could see this is the FEES study which was done, and you can see the aspiration that's going on. So while doing the bronchoscopy, you keep the scope above the glottic opening and you feed, and then you can give milk, you can give any colored solution, and you can see whether the child is aspirating. And here we saw the aspiration. Actually, this child was referred to us. This child had undergone a bronchoscopy before this, and they could not find any answer. So when they came to us, we repeated the bronchoscopy, and we were so happy that we could diagnose. So that's why we did the FEES. Otherwise, there was no need to do the FEES. And we diagnosed that this child was aspirating. So we were happy that this was an aspiration. But what happened is, when we gradually, so when you withdraw the bronchoscope, you do it very, very slowly. So millimeter by millimeter, so you withdraw. So when you did that, you find there is a H-type fistula. So why was the H-type fistula missed in the first place? That was not because the person who was doing it was inexperienced. It was because it was being done by a surgeon who did a rigid bronchoscopy. So the fistula was so high up, it was just below the vocal cords. So when you do the rigid, you often surpass that part with the rigid scope, and that is why there is a very high chance of missing it. So diagnostic is always with the flexi and sharp objects, or if you have problems, any foreign body, you can go for the rigid. So yes, if you have a fistula H-type, so all these can be associated, the vectoral, the charge, and FEES does show an evidence of aspiration. But what was not there was tracheomalacia is rarely associated, was the wrong diagnosis. So tracheomalacia is extremely common. So this was an 8-year-old child who developed diphtheria, and then this child was intubated. This case was Dr. Varinder's case, one of those cases which was not TB. And the question asked was that Congenital subglottic stenosis was seen. The anomaly, what we see, is due to the incomplete separation of the vocal cords, and it can be prevented by using a small size ET tube. So this was the similar case that we had seen, that it was a subglottic web. It is not congenital, it is acquired, and most often it is due to a very thick tube that is put in, the thickest possible tube that is put in. So you accept a little bit of leak, but it's better to use a smaller sized ET tube. You saw a similar case some time back, a 10-year-old child, dermatomyositis on steroids with a 4-day history of cough, fever, and breathlessness, and such abscesses that was there. And this was the finding in the chest, in X-ray, in the CT scan, and the bronchoscopy was done, and what was found was such lesions, such stains. So Zn stain was positive, and again it is in clumps. So the question was that a subcutaneous abscess was seen. So one of the choices were false. Acid-fast bacillus is seen. Antitubercular drugs for 6 months is the treatment of choice, and Septran is the treatment of choice, drug of choice. So no cardiosis, ATD will not work. So it's definitely cotrimoxazole is a drug of choice for 6 months or 1 month after clinical cure, along with the incision and drainage of the abscess. The seventh question, a 6-year-old boy, history of ADHD, mouth breathing, PSG was done, it was suggestive of OSA, was advised tonsilloadenoidectomy, lost to follow-up, and then the child, the mouth breathing had reduced, so evaluation was done before tonsillectomy. So what is this procedure that is being done? So this also we had seen during our presentation on bronchoscopy cases. So this is basically DICE that is being performed. So a drug-induced sleep endoscopy, you put the scope just beyond the choana and in the pharynx, and you see what sort of movement is happening. So this is a drug-induced sleep endoscopy that is being done. And the questions were that what is false? So DICE is being performed. Grade 1 adenoids can be seen. Concentric collapse of the pharynx. Yes, we could see concentric collapse of the pharynx. And it is not always successful. Yes, it is not always successful. So we had a huge adenoid. So that is how you diagnose adenoid hypertrophy. So it's not by X-ray, but by doing a endoscopy. A 9-month-old child, cough, hoarseness of voice, stridor during sleep, history of frequent aspiration, chest X-ray was normal, and this child had a PDA surgery done at 4 months of age. So what was the cause of the stridor? So the first thing was laryngomalacia was the cause of the stridor. Was there a vocal cord paralysis on the right side? And is it due to the damage of the recurrent laryngeal nerve? So these were the 3 choices, and one of them was false, and obviously you could see that there is a damage to the recurrent laryngeal nerve leading to a paralysis of the vocal cord on the left. Okay, so this was a 1-year, 6-month-old female child, cough, fever for 2 months, respiratory distress, hospitalized 2 times. MAN2 was positive, contact history was there, and there was pneumonia in the right upper zone. And here the bronchoscopy was done. You could see on the CT scan there was this pneumonia. And the question was that laryngomalacia is seen, fungal infections are there, foreign body can be seen, and is this an endobronchial tuberculosis? And yes, this was a picture of endobronchial tuberculosis. So you could see this endobronchial tubercular nodes which are there and secretions that are there. Okay, and the last case that we had was a 6-month-old female where stridor was noticed since 1 month of age. This child has, so this is important. There initially we saw the stridor at birth, and here we saw the stridor was noticed at 1 month of age. So here we think more of in terms of laryngomalacias. So what is not seen? A grade 1 laryngeal cleft, vocal cord nodules, tracheomalacia, tracheoesophageal fistula. So what was not seen? So there was a grade 1 laryngeal cleft. There was tracheomalacia, there was a tracheoesophageal fistula, H-type. So many problems was there, but we did not see vocal cord nodules. So that was the answer. So bronchoscopy, the first prize goes to Nikhil Rajvanshi, and his left, huh? Okay. And the second prize goes to Khushbu Taneja. So these are the two. I don't think none of them are here in the hall. Yeah, she's from Rishikesh, no? Yeah. So Meenu ma'am's, yeah. So anyway, so these are the two prizes that are there. I think you can take the first prize, and I'll give the second prize to Meenu ma'am. Have the prizes come? Yes. So first prize to Dr. Nikhil Rajvanshi, and Dr. Goyal is taking it on. Meenu ma'am also is not here in the hall, no? So, okay, we'll give it to her later. Yes, okay. So now we'll come to the radiology quiz. Shubhashish Veer, the radiology quiz.
I will not take more than 5 to 10 minutes because the cases are much simpler and much easier. A 4-year-old child brought with sudden onset of cough for the past 3 days. The child developmentally is perfect. Air entry reduced on the left hemithorax, and the diagnosis is foreign body, congenital lobar emphysema, pneumothorax, pulmonary embolism of the right lung. And the correct answer is a foreign body because there is an air trapping. The bronchovascular markings are visible, so it is unlikely to be congenital lobar emphysema. It is not a pneumothorax because there is no collapsed lung marking. And pulmonary embolism of the right lung basically is normal. So the correct answer is foreign body. A 40-day-old newborn brought with the history of breathlessness since birth, term baby born with vaginal delivery and cried at birth, treated for meconium aspiration syndrome with non-invasive ventilation for 4 days. Tachypnea continues, SpO2 97%, air entry reduced over the left hemithorax, and the diagnosis is, what is the diagnosis? CLE, perfect. Because it is not a pneumothorax, again, there is no collapsed lung marking, and there are some, it is not pneumothorax because the bronchovascular markings, some amount are visible. It is not a meconium plug, and bronchogenic cyst does not produce this sort of picture. So this is a CLE, congenital lobar overinflation or congenital lobar emphysema. 14 months baby, fever, cough for more than 2 weeks, and respiratory distress for 5 days. Maintained SpO2 nasal, by nasal prongs 2 liters per minute, multiple IV antibiotic and nebulization without any benefit. There is a leukocytosis, CRP is pretty high, gastric aspirate for gene expert is negative. Similar past episode 1, mother gives a history of coughing with giving semi-solid, especially khichdi. And this is the X-ray. So in this X-ray, it is, you can well appreciate the opacities in the CT as well as in the chest X-ray. They are pericardiac and parahilar in region, more fitting with a bat wing appearance. And the FFB normal airway anatomy of the dynamics, BAL, TLC 650 cells, cubic millimeter with 60% poly, lipid-laden macrophages 20 to 30%. The most likely diagnosis is tracheoesophageal fistula, sarcoid, lentil hypersensitivity, and pulmonary alveolar proteinosis. And the correct answer is lentil hypersensitivity. Especially, you have a hypersensitive picture like hypersensitivity pneumonia, and there is a history that whenever the mother offers khichdi that's with pulse, the child starts coughing. And the correct answer is lentil hypersensitivity. 7-year-old child developed with history of sudden onset of breathlessness after a cryobiopsy procedure was done to find out the cause for the tachypnea since birth. Now air entry is reduced on the right hemithorax. The diagnosis is pneumothorax right side, blood clot, rigid right main bronchus, congenital lobar emphysema, and type 2 CPAM. It is pretty obvious that this is a pneumothorax with the collapsed lung marking, and no bronchovascular marking. So other possibilities are very distant, and it is not a CPAM, it is not a cystic lesion. So this is a pneumothorax of the right side. 5-month-old infant brought with tachypnea, admitted once for the consolidation of the right lung, and discharged after 10 days of antibiotic, now brought for a specialist opinion. The choices are congenital cystic adenomatoid malformation or CCAM. Earlier we used to say it is CCAM, but now we say it is congenital pulmonary adenomatoid malformation, that is CPAM. Pneumatocyl, it is not a complicated pneumonia. Slowly resolving pneumonia, no, the child is perfectly normal now. There is no fever, nothing. But the child presented with tachypnea. And as the child is having tachypnea, most likely this is going in favor of CPAM. So the correct answer is A, congenital cystic adenomatoid malformation. 1-year-old boy operated for complex cyanotic heart disease, but even 5 days after his surgery, the clinical condition does not improve. Air entry absent in the left hemithorax. Respiratory rate is 60 per minute. SpO2 is less than normal, that is 90%. Air entry is absent. The next best thing is to do is 3% saline nebulization, NSC nebulization, lavage with fiber optic bronchoscopy, and definitely bronchoscopy is the thing that should be done at this age, because the child is not improving, and lavage with a fiber optic bronchoscopy is the most important option and the correct option. 10-year-old girl brought with the history of recurrent fever and cough, wet cough. The child is having wet cough past 6 months. There is no recurrent ear discharge and soft tissue infection. The diagnosis is bronchiectasis, interstitial lung disease, hilar adenopathy, and pleural effusion. There is no feature of pleural effusion. There is no feature of pleural effusion. There is no feature of hilar adenopathy, and more so, it is not a mediastinal cut. Interstitium is not involved. There is a dilated bronchi, and there is a signating appearance. In fact, this child was, though there was no history of recurrent ear discharge, this child was suffering from middle lobe bronchiectasis and primary ciliary dyskinesia. 10-year-old child brought with persistent fever and cough for past 2 months. Father died of tuberculosis recently. The diagnosis is very straightforward. It is hilar adenopathy. It is very clear-cut. It is a hilar adenopathy, so all other options are not correct. A 2-year-old child brought with recurrent tachypnea since birth. Weight is 2.5 kilogram, and present weight 7 kg, clubbing, grade 3 echo, PHT, pulmonary hypertension, and SpO2 is 88% of the room air. The predominant finding is not septal thickening, not bronchiectasis, not emphysema. It is a ground glass opacity. What is a ground glass opacity? Ground glass opacity is an increased attenuation in the CT where the bronchial markings and the alveolar pattern are well maintained and can be visible through the haze. So that is a ground glass opacity, and this child was suffering from APGA3 abnormality, that is surfactant metabolism problem. So the correct answer is A. And 1-year-old child brought with history of fever, cough, and breathlessness past 3 days. USG over the right hemithorax revealed the following. The following are seen in this focus. One is your tissue sign, second is your air bronchogram, and the third is your fractal lines, and the fourth option is all of the above. And all you can appreciate, the air bronchogram is well visible. There is a tissue sign, it looks like a liver, and this fractured line is known as a fractal sign. So the correct answer is all of the above. The following are possibilities with the ultrasound test except pneumothorax, asthma, subcutaneous emphysema, and consolidation. Of course, the consolidation is the odd man out because they are all A lines. Had it been a consolidation, A lines would have been replaced by B lines. So the correct answer is D. And the last case, the 3.5-year-old male with a history of recurrent cough, often with a coryza. But the child is not having any serious manifestation, no respiratory distress, well-maintained saturation, Mann to 10 millimeter with 5 tube. Father recently been diagnosed with tuberculosis. Now, parents got chest X-ray themselves. It has not been advised by any of the treating physician. Now, this is the X-ray. Now, we have 4 options. Is it a positional artifact? Is it a hyperlucent right lung? Is it a thoracic dystrophy? Or it is a hilar lymphadenopathy of collapse of the right middle lobe? Now, position, the hyperlucent right lung is unlikely because there are bronchovascular markings very clearly visible. Thoracic dystrophy, the rib cage is perfectly normal. Hilar lymphadenopathy is not very clearly seen, and definitely the child is grossly rotated. If you see, they appreciate the spine and the medial end of the clavicle. So basically, this is a positional artifact. That concludes all the cases of radiology quiz, and the winners are first prize goes to Dr. Umar Amin Qureshi. Are you here? Any friend of Dr. Umar Amin Qureshi? Javed Iqbal, where is he? And the second prize goes to Bishwadeep Das. I think he is from West Bengal. So we can keep the book and give it to him. Bishwadeep Das. So you can come and take the prize on behalf of Dr. Bishwadeep Das. You are Bishwadeep Das? Oh, please come, please come. I will request Dr. Pallav Chatterjee to hand over the prize. Second prize. So that concludes the academic session. Now, customarily, no, just one second. Yes. Oh, Khushbu has come. Please, please, please.
So the second prize for the
So, Pallav, please wait. Pallav, customarily the valedictory is being given by the organizing secretary, but Pallav has contributed in this conference more than the organizing secretary. So I will request Dr. Pallav Chatterjee to give the valedictory and to say a few words and give the presentations for the award winners. Please.
It has been a fantastic 6-month-long conference. So, had culminated in last 3 days. So the preparation went on and on and on. So thank you everybody. I don't think any valedictory for a respiratory chapter conference held in West Bengal can be complete without remembering Dr. K.K. Ghosh. So I am sure he'll be here and he'll be blessing us. So, and thank you everybody for turning up in large numbers. And I don't think I need to, without giving thanks, I don't have anything else to say. I would ask somebody from the audience to, if you have to say something, please take the microphone and say thank you.
At the very outset, I think all of us would wholeheartedly congratulate the organizing team and also express our gratitude for the excellent Respicon that you people have done. This is probably the second time you have done Respicon. Last time you did it in the other hotel, now you have done it here, and you are getting better and better with time. And there are two particular people which we would like to respect and be grateful. Both of them are, one is on the dais, one is so close to the dais. I think it was marvelous that you people put up with it. We know how difficult it is to conduct a conference. And most parts of the conference, starting from registration to workshops to the 2 days here, despite getting the hall at 3 a.m. in the morning, we were able to start at least by 8:20 in the morning, which was commendable. I just had my morning walk and came to this hall, and I saw Subhashish at 6:40, and he said he was there at 6 a.m. So that is the extent of commitment. And I think we owe a depth of gratitude to every worker. I think these people are visible, but I'm sure there are lots of people who have contributed to the success of the conference. Some of them are seen, some of them are not seen, and the excellent audio visual, the hotel, everything. One word, thanks, is a small word, but when it comes from the heart of every delegate, it is the biggest word. Thank you.
Award ka dekhe. So,
Since we are having flight, so on behalf of IAP National Respiratory Center, I thank Team Respicon, especially Kolkata, for nice arrangement and meticulous and flawless arrangement. Thank you very much.
thank you, thank you. So now is the last part of the conference, presentation of the awards. And we will start off with the poster paper presentation. So I would ask Dr. Jagdish Goyal to please present the poster paper results. The first prize winner is Shiva Kumar Biradar. Is he around? Shiva Kumar Biradar. And the second prize goes to Nagarjun N. And so Nagarjun N is here. So the second prize from the poster paper to Nagarjun N. Okay, now the free paper presentation. The first prize will go to Nupur Mathur. Nupur Mathur. She is around? No. And the second prize goes to Harini Chaudhary. Harini Chaudhary, second prize, free paper presentation. No, they are not available. Okay, now for the award papers. I'll. Certificates. Okay, Saurav Agarwal for the third prize, free paper presentation.
He is our student.
Okay.
You can come forward.
Come. Oh, third prize is there, no? Certificates. Oh, okay. So third prize for the free paper presentation, Dr. Saurav Agarwal.
Yes.
And the third prize for the poster paper presentation will be Khushbu Taneja.
Khushbu Taneja. Oh, great.
Certificate हुई. Okay, so now we'll start with the award paper presentation results. The third prize goes to Annie Basin. So is she there? Annie Basin. The third prize.
नहीं आप दीजिए ना सर आप दीजिए
And she gets a prize money of 3,000 rupees.
Five.
Oh, 5,000. Okay. Second prize?
7. 10,750.
Okay. The second prize goes to Dr. Sheetal Agarwal.
You have to give your account details, we will transfer the money.
This you can't encash, no, what we are giving. It's too big to go. It's too big to go into the drop box.
ये आप लेके जाओ, but send your account details.
Okay, so the second prize goes to Sheetal Agarwal, a prize money of 7,000. And the first prize, sorry for being repetitive, but again to Khushbu Taneja. So that's a prize money of 10,000 rupees to Dr. Khushbu Taneja. So that is all. You want to say something?
Yes.
No. So can we have the national anthem, please?
Before the national anthem, just 1 second, I must thank the event manager group, Tania and Tamanna, the group from Royder. They have done exemplary services to make the program successful. I give a big hand for them.
They are there.
I will call them on the dais, please. Please come. We will have the national anthem right now. Full team, please.
Yes, please.
Team. आइए ऊपर आ जाइए.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गा